Dr. Rajeev Agarwal is working as a Senior Director, Department of Breast Services, Medanta Hospital, the Medicity, Gurgaon. And he got his cancer training from Safdarjung Hospital, New Delhi, and Tata Memorial Hospital, Mumbai. Before joining Medanta, he's been working with many other important hospitals like Sir Gangaram Hospital, and his areas of interest are breast conservation surgery, sentinel node biopsy, public education, and prevention of breast cancer. He's also written a chapter on primary prevention of breast cancer. So over to you, sir. Your opinion about pathologist's role in management of breast cancer.
So good evening, everybody. At the very outset, I must thank Dr. Sunila, Dr. Seema Bhargav, and Dr. Ashwini for introducing me. I think my job has become very easy by all the previous speakers because they were all talking pure science. And now my job is to put forward how a detailed pathological information changes the management of breast cancer at every step during the journey of the management of breast cancer. Let us see what was the pathologist's role as a, before that I will share a very real small story. The year was 1979. I was a house surgeon. A patient of breast lump was admitted. I asked my professor, are we going to do a lumpectomy tomorrow? Well, no, it is a cancer. Without any pre-operative diagnosis, he said, we are going to do a radical mastectomy. Of course, it was a cancer, but he did a classical radical mastectomy and sent it to the lab. And we know what was the report 30, 40 years back of the pathology. So the conventional role of the pathologist was establishing the histological diagnosis. And yes, in the last quarter century, the tumor markers, and of course, the anatomical extent of the disease. But that role is changing now because of the change in the management of the breast cancer, that is neoadjuvant therapy, adjuvant therapy, and the choice of drugs, staging from clinical to pathological to prognostic staging, because prognostic staging in the AJCC 8th edition, there may be prognostic and predictive assessment and the assessment of the outcome. So let us see how the breast cancer clinical presentation has changed in the last 30 years. And that is why we need the change in the pathology overall according to the clinical needs, because we are seeing more early cancer. There is a clinical down staging of the disease, both in the primary and the axilla. Significant number of cases are now non-palpable lesions in the form of either a small SOL or microcalcification. And another very important thing today with the advent of MRI, along with the primary tumor, there is a problem of non-mass enhancement, which needs a tissue diagnosis. And yes, of course, that changes the management. So how the management of breast cancer has evoluted? 30 to 40 years back, there was excisional or incisional biopsy was the norm. Today, it is rarely done. There was no core biopsy or FNAC. Today, the true core biopsy or vacuum-assisted biopsy is a gold standard. There was no pre-treatment assessment of the axillary node. Today, the pre-operative FNAC or core needle biopsy of the axillary node is frequently done. Mastectomy with axillary dissection, that was the standard. Today, a significant number of cases are going for breast conservation surgery with sentinel node biopsy. As I said, there was no concept of non-palpable node. Today, both in primary as well as post-NACT, significant number of cases have non-palpable nodes. Till about a quarter century, there was no concept of neoadjuvant chemotherapy, except particularly in early breast cancer. Today, almost 50% patients are going for neoadjuvant chemotherapy. And of course, there was no molecular or genomic testing. Today, molecular or genomic testing has become the norm. So what I have done in the next 10-12 minutes, that I have taken various steps during the journey of management of the breast cancer. What are the challenges for pathologists and how pathologist, that reporting of pathology is changing the management of the breast cancer. I will share some of the case studies. So the challenge for pathologists at the core biopsy, the tissue is very small, and we ask too much of information from that small tissue biopsy, the morphological diagnosis, the prognostic or predictive tumor markers, whether there is an in situ component or not, and of course, the histological prognostic factors. And in the nodal disease also, we are doing frequently FNAC or core biopsy of the axillary node, and pathologist has to report whether this node is positive or negative, because that changes my management. Another very important thing is that PET is the norm. And during the PET scan, we are finding a lot of time a neck node or a mediastinal node, and which is PET positive. So now the question comes, what to do? And so a EBUS FNAC or a small FNAC of the cervical node where the tissue is even small, the pathologist has challenge to report what it is and how it changes the management of the case. If you see these two cases, the age, the tumor size, the nodes are same. The IDC grade is the same. The difference is in the tumor marker. On one side is the triple negative breast cancer. On the other side, it's a luminal cancer, ERPR positive, HER2 negative. The first case will go from today's standard for neoadjuvant chemotherapy, while the second case will be subjected for primary surgery. So that is how on a core biopsy, a good pathological information changes my management. Next is per-operative also. Today, pathologist has a very important role to play during the surgery also, because a lot of time we are doing breast conservation surgery. Few of my colleagues are doing a mammogram of the specimen to know the margins, but I am in person is more comfortable that I send the specimen to pathology. They cut open the C, and if any margin is closed, they report to me, or they take a frozen section. I know it is difficult to do all 6 margins, but since we are taking little more margins, so most of the time they may have to take maybe frozen of 1 or 2 margins. And this conservation is both for primary as well as post NACT cases, as Dr. Sonam mentioned. And a lot of time we are doing breast conservation surgery, and there even it is a bigger challenge for pathologists to see the margins. And of course, sometimes within the breast conservation surgery specimen, there may be a second focus of primary, or there may be in situ carcinoma. Similarly, though in Western countries, they are not doing frozen section for the sentinel node, but in India, we are doing frozen section for the sentinel node. Again, for untreated primary, that is virgin case, as well as post neoadjuvant chemotherapy. The challenge is minimum time and acceptable false negative rate, because if sentinel node is positive, I have to go for axillary node dissection in most of the cases. If the margins are close or positive, I have to go for revision of margin. And of course, post surgery, we have to send the specimen to the laboratory, and the pathologist has to see usual reporting, conventional reporting. Then in breast conservation surgery, all the 6 dimensions has to be seen. They have to see for invasive cancer, for DCIS on the margins. And over time, the negative margin definition has changed from 1 centimeter to no tumor cells on the inked margin. They have to see for DCIS component. They have to see for additional satellite nodule. They have to see for multicentric disease. And because breast is a heterogeneous disease, the individual morphological and genomic markers sometimes may be important. Another very important thing is intra-mammary node, because as per new AJCC classification, if the intra-mammary node is positive for malignancy, it changes the stage. Even if the sentinel node is negative, it changes the stage from N0 to N1. Similarly, the axillary node re-examination has to be done for isolated tumor cells, for microinvasion, or macrometastasis. And of course, the number of positive nodes, because today the most important thing is in the axillary dissection is number of positive nodes, because that changes the stage of the disease, and of course, a extranodal infiltration. And again, these are the 2 cases. Similar age for 55 years, T2 disease. In one case, ERPR positive, HER2 negative, but the oncotype DX score is 30. For a 55-year-old lady, the oncotype DX score 30 is higher score. She will go for chemotherapy and hormonal therapy. While a same age patient, if the oncotype score is 23, this patient will go for a hormonal therapy alone. She can be avoided chemotherapy. But in the same scenario, if the age is 45 and the oncotype score is 23, this patient again will be subjected for chemotherapy and hormonal therapy, not radiotherapy, hormonal therapy. And another, the bigger challenge that Dr. Sonam beautifully mentioned is today in the era of NSCT, post-NSCT, because it is difficult sometimes to assess primary residual disease because the definition of pathological CR is changing, whether the presence of DCIS we should take as pathological CR or not. And particularly when there is a clinical or radiological complete remission, assessment of these cases, finding the tumor bed is a very big challenge and needs a very close coordination between the surgeon, the radiologist, and the pathologist. Similarly, in the nodal disease, the pre-treatment FNAC was positive. Now in a PET scan or ultrasound, FNAC is negative. An increasing trend of the central node, that is de-escalation of axillary disease post-NSCT, is getting popular. So there is a challenge for pathologists to do a frozen section in a treated lymph node. This Dr. Sonam has mentioned beautifully. I will skip this slide. And again, this is another case scenario where there's a patient is T2N1M0 disease. It was triple negative cancer, NACT given. If there is a pathological CR, no further chemotherapy will be given. But if there is a no pathological CR, then there will be more chemotherapy in the form of oral capecitabine. Similarly, in the scenario 2, it's a T2N1 disease. ERPR was negative, but HER2 positive. This patient usually are being treated with neoadjuvant chemotherapy plus targeted therapy, maybe dual agents. If there is a pathological CR post-operatively, only Herceptin will be continued for a year. But if there is no pathological CR, along with the Herceptin, the dual agent, that is pertuzumab, may also have to be continued. So that is how the pathology report is helping us to change the management of patients in breast cancer. Another new thing, because we are detecting now day by day screen detected non-palpable lesions, which may be a small SOL or a microcalcification or a small papillary lesion which is detected on ultrasound or MRI. And our own studies, we have shown that 20% of the papillary lesion may have element of malignancy. So these patients have a challenge for radiologist or pathologist because we have to do a stereotactic or ultrasound guided core or web biopsy. The tissue may be very small, and the usual challenge of diagnosis, whether it is a benign papilloma or papillary DCIS or encapsulated papillary carcinoma or so on and so forth. An unexcised specimen, when we operate these patients, particularly microcalcification that I'll be showing one or two cases, the assessment of the T size is a very difficult thing because there is no gross tumor, there is no palpable tumor. So that's a challenge for for pathologists to give me a correct T size of these non-palpable lesions. So this is a case where it was a 70-year-old female, screen detected very small lesion. Ultrasound guided biopsy was an atypical papillary lesion. I did a wire guided excision. Morphologically, it was looking like DCIS, but on detailed examination, it turned out to be IDC. ERPR is positive, HER2 is negative, FISH report is awaited. And this is a patient, if you carefully see little white spot, about 8 millimeter tumor, about a half a centimeter away from the tip of the marker. We excise this, tumor is little more visible. So such a small tumor, want to have so much of information is a challenge for pathologist. Another patient, very small screen detected microcalcification only. There was no palpable tumor. This is the again wire guided excision, and we have done this wire guided excision, and this is the microcalcification. In these patients, we always do a specimen mammogram to see whether complete microcalcification has been taken out or not. So these are little examples how a pathologist today in day-to-day helping the clinicians. And to conclude, I would like to say that the treatment of breast cancer has shifted from approach of one size fits all to one of the personalized treatment tailored to the specific characteristics of the tumor. Pathologists now have the additional role of identifying biomarkers responsive to therapeutic manipulation, thus playing an important role as diagnostic oncologist. So today I call my pathologist as diagnostic oncologist in the management of breast cancer, and they are a very, very important member of the multidisciplinary team. The role of pathologist as a diagnostic oncologist thus involves the complete spectrum of continuing of cancer care and extend from prevention and screening through diagnosis to prognosis and prediction of the therapeutic responses and monitoring of the disease. This role has now been extended to include the molecular aspects that allow greater insights into the pathogenesis and treatment of cancer. Thank you.
Thank you, sir, for that excellent talk. And it's wonderful that you have such a good opinion about pathologists, because I do understand, being a breast oncopathologist, even my breast oncosurgeon insists that I accompany her to the radiology room and look at the specimen mammography to ascertain that the specimen is actually completely taken, and so that it becomes useful. So, so thank you for calling us the diagnostic colleagues of you, and it's always nice to have the clinicians giving us the impression that how helpful we are.